morning to all. I am presenting today tuberculosis and typhoid, which is infectious disease of surgical importance. I am presenting today etiopathogenesis and the clinical presentation. Tuberculosis. First is tuberculosis. Incidence of tuberculosis constitute 1/3 of the global of the whole world in India, of which 3.42 lakh per year are of 0 to 14 years of age. Cause of death is Mycobacterium tuberculosis, which is a gram-positive acid-fast bacilli and is aerobic. The types of the tuberculosis are pulmonary and extrapulmonary TB. Most commonly it is pulmonary. In extrapulmonary, most commonly it involves lymph nodes, GI and the CN other systems. First is most common involved system is lymph nodes. Tuberculosis lymphadenitis is most common extrapulmonary TB and most commonly involved upper cervical lymph nodes and spread through tonsils. The stages of tuberculosis lymphadenitis include in stage 1, when in early stages lymphadenitis, there is discrete nodes which are non-tender and hard to palpate. In stage 2, when there is periadenitis, they move together in mass and causes matting. In stage 3, cold abscess, which is deep to deep fascias and form after the when there is increase of necrosis and the caseating formation is more. Then further there is formation of cholesterol abscess, which formed when there is rupture of the deep fascia under the skin, but there is no perforation of the skin. When there is there is skin involvement, there is sinus formation and the necrosis and the caseating particles comes out. The most common lymphadenitis is most commonly hyperplastic or caseating type. Caseating is more common and hyperplastic is less common, and present is discrete and formed or hard lymph nodes. In hyperplastic, there is involvement of cortex of the lymph nodes, and that's why drugs act better in it. Hyperplastic is present in the patients which have who have host immunity, good host immunity, and spread by hematogenous route. In caseating type, it involves medulla of the lymph node and causes periadenitis and therefore more chances of the resistance of the drugs, and occurs in the patient who have poor immunity and spread from tonsils. Mostly present as painless swelling in the neck, and the basic symptoms of the tuberculosis type B constitutional symptoms, which are anorexia, weight loss, and the night sweatings. On examination, there are absence of signs of inflammation, that's why known as cold abscess. Second is abdominal tuberculosis, which can be divided in primary and the secondary abdominal tuberculosis. Primary is when there is no other pulmonary or elsewhere foci of the tuberculosis and occur primarily in the gastrointestinal system. Secondary abdominal TB is when there is primary foci of tuberculosis elsewhere in the body. Types of the abdominal tuberculosis. First is intestinal type, which is also known as Koenig syndrome, which is divided into ileocecal and ileal. Ileocecal is ulcerative, hyperplastic, or ulcero-hyperplastic mixed part, and the ileal part is present as stricture type. Second is peritoneal, which can be present as acute or chronic. In chronic, there can be ascitic, encysted, plastic, fibrous adhesive, or purulent type. Then other parts which can be involved in the abdominal TB is mesenteric and its lymph node, anorectal sigmoid, involvement of other organs like liver, spleen, which can be present as miliary TB, the tuberculosis of omentum, and the rare presentations are esophageal, gastroduodenal, and retroperitoneal. The pathology of the tuberculosis in abdominal TB, the patients who are malnourished, poor resistance patients are present as ulcerative or stricture type. However, well-nourished and good resistance who have good immunity present as hyperplastic or nodular tuberculosis, and other can also be present as combination type, which is also hyperplastic. Tuberculosis can be spread by direct ingestion of the primarily when there is contaminated by food, and secondary if there is pulmonary TB and it contaminate which contaminates saliva, and the TB is and abdominal TB spread from the contaminated saliva. Second is pathogenesis route when the spreads from the lung, or local spread when there is inclusion of the cervical lymph nodes. It can also retrogradely spread from the fallopian tubes to the peritoneum and direct from the adjacent organs. Clinical features of the tuberculosis, which are basic constitutional symptoms: low-grade fever, malaise, night sweats, and weight loss. Particularly in abdominal TB, it can be present according to the types of the TB. Like in ulcerative, patient present as diarrhea or malabsorption. And structure type, it can be present as obstruction, subacute or acute. In hyperplastic type, it can be present as mass abdomen, most commonly in right iliac fossa when including mesentery, or can be present as obstruction. And ascites, abdominal distension. In peritoneal included abdominal cocoon or the doughy abdomen. And when include mesenteric, it can be TB's mesenterica or obstruction, which is enlarged lymph nodes of the mesentery. Then first is ileocecal, which is most common abdominal TB tuberculosis. It in this also ulcerative part is most common, and present as lesions or napkin ring strictures or and bowel adhesions. Patient present mostly as diarrhea or blood in stools. In hyperplastic type, there is fibrotic reaction in submucosa and the subserosa, which cause the hyperplastic and nodular formation, and occurs in young, well-nourished patients. Most commonly include cecum. Extensive adhesions are present in the right iliac fossa, so patients present most commonly as mass in the right iliac fossa or subacute obstruction. This present more commonly as primary TB, that is not no other primary foci elsewhere. In barium study, we can say build up cecum and obtuse ileocecal angle. The second type is peritoneal tuberculosis. That is a thickening and fibrosis of the peritoneal wall. And it present as ascitic type, also known as wet type, which is more common, or dry type include fibrosis and adhesions of the peritoneum. And it also can occur as obstruction and distension. And this there is abdominal cocoon and loculated purulent or ascites is seen in the peritoneum during. In the pathology, there is thickening of parietal peritoneum with yellowish tubercles, and the abdominal cocoon present, which is the dense adhesion in the peritoneum, and omentum with small bowel as contact. The thickening of bowel loops causes adhesions. And the acute presentation mimics acute abdomen, and on table diagnosis, we can see the straw-colored fluid or the tubercles in the peritoneum, omentum, and the bowel wall, which was on-table diagnosis of the acute peritoneal tuberculosis. When present as chronic, there can be formation of doughy abdomen, thick abdomen, fibrous, and or rolled up omentum. This can present as ascitic ancestor ascites, which is loculated formation of the fibrinous deposition, dullness. We can on examination, dullness can be present, which is not shifting type, as this is loculated part, and the abdominal mass. Then third is plastic, and fourth is purulent, which can present as tubercular salpingitis, mass in the lower abdomen containing pus, and the genitourinary TB can also be present as this. Then there is tuberculous mesenteric lymphadenitis involving mesentery, commonly involving right side, right iliac fossa. Patient present with right iliac pain or mass. There is a pseudomesenteric cyst, which is caseating caseating material present in between the mesentery. And the TB is mesenterica, which is enlarged lymph nodes of the mesentery. Then in anorectal sigmoidal type of tuberculosis, patient present mostly in frank blood in stool, hematochezia, multiple fistula, painful and characteristically, which are characteristically not indurated on palpation. And the ulcers form are the bluish and undermined edge, which are characteristic of the tuberculosis. Omentum, when the involvement of the omentum, there is a rolled up omentum can be there. The other organs which can be involved are liver, pancreas, and spleen, and mostly involved present as granuloma and hepatomegaly, obstructive jaundice in pancreas. There can mimic malignancy, and mostly involvement of pancreas are there in immunocompromised patients. And spleen, there is splenomegaly and or multiple abscess of the spleen. The other system which can be involved in the tuberculosis is genitourinary. With in genitourinary system, most commonly involved earliest involvement is renal cortex. Then that spread to the ureter, causes ureteritis, and in ureter it's mostly involved VUJ, then pelvic ureteric junction. In if tuberculosis can involve bladder, tuberculous cystitis is formed, and this fibrotic part is of the bladder is known as thimble bladder. The pathologically types of the genitourinary tuberculosis can present when involvement of the papillary ulcer, and can be the hydronephrosis, pyonephrosis, perinephric abscess, or pseudocalculi, or the putty, or when the gaseous material includes all the renal kidney, and then biliary TB can also be there. In symptoms other than basic constitutional symptoms of the tuberculosis, there can be sterile pyuria, painful micturition with hematuria, and fever and weakness. This tuberculosis. Second is disease is typhoid. Typhoid includes annual global incidence of the typhoid is 21 million cases in India, affects predominantly in school general. Most common surgical complication is typhoid intestinal perforation, which we are dealing in surgery. The pathogen include is the Salmonella typhi, which is gram-negative bacilli and triple-native analog. Typhoid spread mainly from the ingestion of the contaminated food and water. It spread to the small intestine, then reaches Peyer's patches, and reaches to the other various organs and causes various diseases like osteomyelitis if in bone marrow bone, and the abscess if the local skin spread, and then from intestine it spread to the bile and which secrete in gallbladder, include gallbladder causes cholecystitis, and then further Peyer's patches involvement, if there is formation of the abdominal ulcers, intestinal ulcers, and necrosis causing intestinal perforation and bleeding. The surgical complications are intestinal perforation because of Peyer's patches involvement, intestinal bleeding, cholecystitis, perforation lymphoma can be there, osteomyelitis, and abscesses in different regions, hepatic or splenic abscesses, pleural effusion, and orchitis. These are the rare including organs. Then presentation of the typhoid is mostly late presentation, as it is common common features are fever and generalized weakness. Most common patients present as abdominal pain, which is around median 9 days of infection. Then can be involved early presentation is diarrhea, and in late course of the disease, it can involve constipation. Patient present is blood in stool, jaundice if involvement of the gallbladder, then pain at the osteomyelitic site in osteomyelitis. In both tuberculosis and the typhoid, surgical part is mostly commonly because of ulcer. So there are some differentiating feature of tubercular and typhoid ulcers. In tubercular ulcers are can be there in anywhere in the intestine, most commonly in the ileocecal junction, and the whereas typhoid ulcers are in small intestines. Tubercular ulcers are transferred to long axis. However, typhoid are longitudinal to long axis as spread through Pear's patches, which are aligned like in longitudinal axis. In the tubercular ulcer, it is spread via lymphatics, which align circumferentially. So there is formation of the transverse ulcer. There is in pathology microscopy, there is granuloma with central area of necrosis present in the ulcer. In typhoid, there is formation of lymphocyte and the plasma cell. In tuberculous ulcers causes commonly present as strictures. However, typhoid commonly present as perforation and hemorrhage. मैकबुक से करा था तो चेंज हो गया इसलिए पीडीएफ से जब मैकबुक से करा था तो वो चेंज करने में पीडीएफ चेंज
तुम आपस में मॉडरेट करते हो ना या वो इंडिपेंडेंटली करते हो so next time if you are presenting in PDF you open it in Adobe and do next page don't miss this transition is not smooth.
We'll now move on to the diagnosis and treatment of these two diseases. So we look at pediatric tuberculosis first. And here we primarily cover the extrapulmonary tuberculosis, which includes the TB lymphadenitis, the abdominal TB, and the genitourinary TB. We'll add a short note on the pulmonary tuberculosis of diagnosis and treatment as well. The guidelines of pediatric TB management were published by the Central TB Division, and these were developed by the National Tuberculosis Elimination Program, and the management of tuberculosis under these guidelines. So coming to the extrapulmonary TB, so diagnosis primarily is that the children present specifically with organ-specific symptoms, and in addition to the constitutional symptoms. And this diagnosis is based on the history, the presentation, and other supportive investigations. And like we've seen, the organs of extrapulmonary TB involvement are the lymph nodes, the intestine, the genitourinary tract, and less commonly the pleura, the bones, joints, and the meninges of the brain. So it is important to rule out alternative diagnosis diligently before we move on to the diagnosis of tuberculosis. Coming to the diagnosis per se, with the help of nucleic acid amplification test, the sensitivity of this test is low and moderately high in specimens such as pus, biopsy, aspirates, or any tissue culture or CSF. It is important to note that the sensitivity falls in samples such as ascites, pericardial fluid, synovial fluid, and it is far more lower in pleural fluid aspirates. So a negative culture or a negative CBNAT cannot rule out tuberculosis because of inadequate sensitivity of these tests in the extrapulmonary specimens. This is a very important point. Coming to the tubercular lymphadenitis per se, so this is most common and presents in children between the age group of 5 to 9 years. Here there is persistent lymphadenopathy for more than 2 weeks in one or more areas, or the child might present with a single lymph node of size more than 2 centimeter, or matted lymph nodes, or with a chronic sinus. So the child might or might not have constitutional symptoms, and particularly it should be suspected in children with no evidence of scalp or skin lesions in the draining areas. So tuberculosis is unlikely if the lymph nodes are small, less than 2 centimeters, or maybe persistent for a very long time without any systemic symptoms. Coming to the investigations, ultrasound is the very key and chief first investigation to be done with characteristic central hypergenicity seen. Then chest X-ray, around 5 to 40% of these children have associated pulmonary tuberculosis as findings, and gold standard is the histopathological examination of the excision biopsy specimen. FNAC also can be done because almost it correlates with biopsy in 90% of cases. It is important to remember that reactive lymphadenitis in the neck may clinically mimic tuberculosis, and anti-tuberculosis drugs should not be given unless the diagnosis of TB is confirmed by these tests, like the smear for AFB or CBNAT or a mycobacterium growth indicator tube, or suggestive diagnosis is given with an FNAC or HB. Coming to the algorithm that is proposed by the pediatric TB guidelines of the NTP. So if there is a child with a peripheral lymph node which is more than 2 centimeter and one or more sites, first we have to look if it is matted or if there's any cold abscess or if it is a sinus. If these are not present, then antibiotics should be given, at least recommended for 2 weeks, and then we review for response. If there's no response, or if any of these things are present, then we aspirate the pus, or if pus is not there, then we do the FNAC of that lymph node and send it for test for TB. Now, if this comes positive, then we treat for tuberculosis. If this is not positive, then we proceed for excision biopsy. So this is the common algorithm that we tend to follow in our patients of tubercular lymphadenitis. And if excision biopsy again is positive, then obviously treatment for tuberculosis is done. Otherwise, we have to consider alternative diagnosis. Now, chest X-ray is recommended if the lymph node size is more than 2 centimeters or any of these features is present. And if chest X-ray is again abnormal, then, or if any of these is positive, we treat for tuberculosis. Coming to abdominal tuberculosis, the types like Ananya mentioned were the intestinal, the nodal, the peritoneal, visceral, or even disseminated TB. So 1/3 of patients have involvement of more than one sites, and multimodality evaluation is required, starting from clinical evaluation, laboratory tests, radiology, endoscopy, microbiology, and histopathology. Tissue diagnosis is the most reliable of all, and but this is often not feasible, especially cases that present early. So history and examination, the symptoms depend on the type of abdominal TB, and they can be varied from abdominal pain, fever, weight loss, all these general symptoms, including jaundice, hepatomegaly, splenomegaly, etc. But it is very important to remember the red flag signs of abdominal TB. There are 4 signs described, which are supposed to be the red flag signs of abdominal TB. That is one, child with pain abdomen, that is waking the child from sleep, or the child has chronic, severe, or nocturnal diarrhea, or the child has gastrointestinal bleeding, or there is localized distension or mass. Coming to the algorithm, if abdominal TB is suspected based on history, then we look for peripheral nodes, get a chest X-ray, get an abdominal ultrasound. So if ultrasound is suggestive of TB, then and if chest X-ray is abnormal, then you start anti-tuberculosis treatment directly because abdominal TB is most commonly secondary with a pulmonary focus. Or if there are peripheral lymph nodes positive again, then TB treatment is started. But if none of these is there, only ultrasound is suggestive of TB. That is, ascites is there, lymphadenopathy, or ileocecal TB presentation is there. Then, depending on the type of sample we can obtain for tubercular diagnosis, we try to obtain the ascitic fluid by aspiration, then send it for cytology, proteins and sugars, and then look if it is an exudative sample type with lymphocytic predominance. Then we send that fluid for CBNAT, and if it is positive, we start the treatment. Then, if it is a lymphadenopathy, abdominal lymphadenopathy, we can get an ultrasound, get an FNA done from the abdominal mesenteric lymph node, and send it for the same analysis. If it is an ileocecal TB, then it warrants a CCT abdomen or a CT enterography to confirm the diagnosis. So CT findings suggest of there is a term called the CT enteropathy, wherein there is involvement of the ileocecal area with thickening of the bowel wall, and usually there is a uniform and concentric bowel wall thickening. There could be a contracted and pulled up cecum. The ileocecal angle is distorted, often obtuse, and there may be strictures also seen on CT. Abdominal lymph nodes may be enlarged with central necrosis, or they may be conglomerate lymph nodes with peripheral enhancement. Mesenteric thickening also is seen with cake to mentum and other, if space occupying lesions are there in the viscera, they also can be treated. So signs of importance usually that we tend to see and describe are the Fleischner sign, which is, this is seen on contrast study on the barium enema, by the way. So there could be a narrowing of the terminal ileum, thickening and gaping of the ileocecal valve. There can be thickening or hypermotility of the cecum that is seen during fluoroscopy. Sterling sign often refers to the repeating and emptying of the cecum that is seen on fluoroscopy. There could be conical cecum, which is shrunken in size, and pulled up cecum. So on laparoscopy, what we usually tend to see are common 3 findings, and this is usually very highly sensitive and specific for abdominal TB. So we could either see a hyperemic peritoneum with ascites or with whitish miliary nodules, or there may be these hyperemic peritoneum with ascites and many dense adhesions in the abdominal cavity, or they may be markedly thick peritoneum with yellowish nodules studded on the surface of the peritoneum and multiple thick adhesions. Either of these three can be present. Coming to the management per se. So we start the treatment and follow up as per the National Tuberculosis Elimination Program. So ATT is the core and the crux of management of a TB abdomen patient, wherein a 6-month course of HRZD plus HRE regimen is given, with pyridoxine supplementation given every day. Then coming to the surgical management per se, the primary indications of surgical management in a TB abdomen patient are if the child presents with acute obstruction, or if there is intestinal perforation, or there are persistent symptoms of subacute intestinal obstruction that is not getting relieved with conservative management. Coming to the other supportive management, this forms the third prong in the approach, wherein treatment for malnutrition and SAM should not be ignored, because these children respond well only when malnutrition is also corrected and tackled at the same time. It is important to remember that unlike pulmonary tuberculosis, steroids are not useful and recommended by the NTP for abdominal tuberculosis. The other important aspect is that no empirical ATT is supposed to be given if any child presents with a recurrent chronic pain or has chronic diarrhea without proper evaluation and has no red flag signs. So that's where these red flag signs come into picture. So there's no role of any empirical ATT in abdominal TB.
Pulmonary tuberculosis, what are the indications?
Sir, in pulmonary TB, basically they are recommending steroids along with the ATT, sir, because the inflammation over there
All patients.
in almost all patients. I'll be dealing with the pulmonary TB in the next slides. So coming to the surgical management per se, in case of evidence of any obstruction, so on table on laparotomy, if you find a solitary stricture, then a stricturoplasty is recommended. Then if there are multiple strictures, either of the two things can be done. If they are present in long intervals, then we perform individual stricturoplasty at each site. If they are present within a segment, within a short segment, then a resection anastomosis is recommended. It is important to remember that a stricture within 10 centimeters from ICJ is best treated by resection and not stricturoplasty. And a stricture which is more than 12 centimeters again is best resected and not plastic. So stricturoplasty
also accepted more than 12 centimeters.
Single stricture within 10 centimeters of ICJ resected, sir, and if it is more than 12 centimeter length, resected. So the stricturoplasty is performed by a longitudinal incision over the stricture and switching it in transverse fashion. This is by the Henke-Mickens principle. So, अगर stricture length more than 20 centimeter end with the stricture. So.
Even 5 centimeters.
Sir, these are written in.
I don't think
it is not written anywhere.
The length is more than 3 centimeters. Whatever it is, if it's more than 3 centimeters.
सर एक जनरल सर्जरी का ओके
Why are you talking something which is not? 3 centimeters.
It's not written anywhere else.
हमारी क्लास में वो टॉपिक करते हैं सर
It's not visible what they are saying.
Yes.
3 centimeters is for 60%. Then modified by the side to side procedure if at all.
In case of hyperplastic TB, that is the TB involving the ileocecal junction presenting as a mass, limited resection is recommended by removal of the terminal 8 to 10 centimeters of ileum, cecum, appendix, and the disease portion of the ascending colon, and performing an ileocolic anastomosis. In case of perforation of the intestine, in the case of abdominal TB, the ideal treatment recommended is the resection anastomosis, because primary repair of the perforation has a very high chance of leak and fistula formation. And also in case of severe contamination of the abdomen or the poor general status of the child presenting in shock with hemodynamic instability, exteriorization of the bowel in the form of stoma formation is recommended. In case of adhesions, laparoscopic adhesiolisis can be, if there is no evidence of perforation and the child has obstruction, the laparoscopic adhesiolisis is enough for the management of this child. And in cases of other situations such as intra-abdominal abscesses or intracutaneous fistulas, appropriate management according to the clinical condition along with antituberculous treatment usually suffices. Coming to how to monitor these patients after surgery. So assessment of response is primarily by clinical follow-up. Follow-up is supposed to be done monthly during treatment and 3 monthly later. And radiologically, at the end of treatment, that is at the end of ATT, ultrasound is supposed to be done, and or ultrasound is supposed to be done in between if there is worsening or non-response to treatment. Microbiological follow-up that will be in the form of cultures or repeat sampling is supposed to be done in case of worsening or non-response to treatment. The pointers towards drug-resistant tuberculosis are any child with who's non-responding or worsening or deterioration of constitutional symptoms after starting initial ATT. So that could point towards drug-resistant tuberculosis, and investigations towards that should be carried out. Obstructive symptoms may persist or worsen during ATT treatment. This is supposed to be clearly explained to the patient beforehand, and active diligent follow-up for days is supposed to be done. Monitoring for ATT-induced drug reactions again at every visit and adherence to treatment is to be documented. Coming to genitourinary tuberculosis, this is very uncommon in children because symptoms of renal TB do not appear for 3 to 10 or even more years after primary infection. So this is unlikely to see to be encountered in a child who is less than 5 years, and less than 3% of pediatric TB are genitourinary. Primarily, they are pulmonary or abdominal tuberculosis. Early diagnosis of genitourinary TB is almost such that ATT itself is curative and no surgical intervention is required. So the diagnosis for genitourinary TB in a case that presents symptomatically with such symptoms are by sending a urine for TB bacilli, but this has a very low detection rate. Just about 30 to 60% cases are positive for bacilli in the urine. But urine PCR, on the other hand, is more sensitive and specific, and a faster result could be obtained. So this is a better way of diagnosing it. In late cases of TB, genitourinary TB, radiological signs and radiological features can be seen, such as calcification, cortical scarring, calcial cavitation or destruction, non-visualization of the kidney, or in case of ureteral involvement, strictures can be seen. In case of bladder involvement, irregular or small capacity bladder fasciitis. Here, in this case, you can see a calcified and a putty kidney in a late stage of genitourinary TB. Diagnosis by cystoscopy also can be done, wherein findings such as multiple tubercles leading to a cobblestone appearance, or just even mild erythema and edema of the bladder wall, or there could be hemorrhage on the bladder wall, or in case of late presentation, there could be scarring of the bladder wall, and golf hole like ureters ureteric orifices can be seen, or even bladder calculi can be. Coming to the treatment, the cornerstone in management, like we first discussed, the anti-tuberculosis treatment. And the role of surgery is primarily complementary, and a minimum of 4 weeks of drug therapy is actually recommended at first before any surgical intervention is done. And this period not only allows the stabilization of the renal lesion, but also allows in treatment planning. It helps us decide if conservative management with ATT alone is sufficient, or any reconstructive surgery needs to be done if the child is a late presenter. And this period of the 4 weeks of ATT also aids in any functional recovery if the renal impairment has occurred due to tuberculosis. And during this time, a temporary urinary diversion in the form of just Foley's catheterization or a PCN is also recommended. Coming to the treatment per se, it is fairly simplified with respect to the function of the kidney. So if the lesion involves the parenchyma or the kidney is non-functioning despite the drainage of the obstructed lesion, a nephrectomy is recommended. And if there is contiguous ureteral involvement in the form of strictures, then a nephrectomy is done. And if renal function is preserved and this lesion is stabilized after chemotherapy, but reconstruction is required in the form of either a ileal replacement for the ureteral stricture or augmentation cystoplastic can be done for the blood. Coming to pulmonary TB in brief, so the diagnosis here primarily is with the help of the triad of symptoms of persistent fever, a cough more than 2 weeks, a significant loss of weight of more than 5% in the last 3 months, or a failure to gain weight in the past 3 months despite adequate treatment. So, detailed history, examination, and investigations for TB are recommended in cases that present like this. So, with those symptoms, first investigation is usually a chest X-ray, and if the chest X-ray is normal or suggestive of TB or is non-specific, would guide the next algorithm. So, if it is normal, then a child with these symptoms should be looked for any extrapulmonary TB, and a detailed investigation for TB is supposed to be done after the alternative cause of these symptoms is ruled out. Even a CT test may be required. If this X-ray is highly suggestive of TB, which the findings we look in the next slide, then the expectorated sputum is to be sent for gram stain, AFB, a CVNAT, and if that is positive, then it is a microbiologically confirmed case of TB, and rifampicin resistance is supposed to be checked, and accordingly, treatment with ATT started. Then, if the chest X-ray is non-specific or the sputum is CVNAT negative, then what do we do? So we actually give a course of antibiotics for 2 weeks and then proceed to the next step. And if the persistent shadows on the chest X-ray after 2 weeks also, then we look for any other site, extrapulmonary TB site, and we can consider repeating a CVNAT from a better quality specimen or an alternative specimen like a bronchoalveolar lavage or an aspirate or lymph node aspirate, or depending on whatever is available. Then again, if that is negative, then no other diagnosis is likely, then we have to treat it as a clinically diagnosed case of TB. Here, probable the term uses probable TB. So the findings that we usually can see on the chest X-ray are these findings can be seen even in our surgical patients. So that it's important to remember that pulmonary TB can overlap any other surgical condition as well. So recognizing these clinical findings on chest X-ray is important. So the first thing could be a simple hilar nodal involvement in the paratracheal region or a hilar region, or we could have a lymph nodal mass with significant airway compression. And so here suggested by the right-sided hyperinflation of this lung because there's a partial obstruction of this airway. Or there could be a lymph nodal mass with adjacent consolidation. Or there could be a cavitary pneumonia. There's a cavity here and adjacent consolidation in this right lung. Or there could be miliary shadows in both the lung fields suggestive of TB. Or there could be extensive disease with multiple areas of breakdown, and this is fibrocavitary pneumonia. The other ancillary tests for diagnosing TB are the tuberculous skin test, wherein more than 10 mm area of erythema is positive. But if in the case of HIV co-infection, more than 5 mm is considered positive. Interferon gamma release assay is also done for TB assay, but these are only supportive. There is a next generation skin test developed by the State Serum Institute in Copenhagen. This is an easy to use point of care test, has a IgRA-like performance, and is based on the surface antigens of TB. But this is currently commercially not available in India, and the proposal to make this available and was made last year itself. But as of now, what I found, it is not yet available. The treatment of pulmonary TB primarily is ATT, and the TB regimen initially started for all microbiological confirmed rifampicin sensitive cases is or a case of clinically diagnosed pulmonary TB or a case of drug sensitive previously treated TB. All these cases, it is 2 months of HRZD with 4 months of HRE. And in children, a weight band method is used, wherein children are divided into weight band ranges, and a fixed drug combination of TB drugs are given according to the weight bands. Then we move on to typhoid. So this slide, sorry. So steroids, sir, are given in cases with miliary TB with hypoxia, or endobronchial TB, or disseminated TB. Here, prednisolone with a dose of 2 mg per kg daily is given, or a dexamethasone 0.6 mg per kg per day for 4 weeks. This dose is gradually reduced over the next 4 weeks before stopping.
Not used in all.
Disseminated miliary TB or endomorph.
Regarding abdominal, previously it was being used, because if you have read it and it has changed, then it's different.
Yes.
But in cases where partial obstruction is there, then when we are starting, partial obstruction can get converted to abdominal. So used to be steroid to reduce the edema,
Yes.
and we are starting this.
Yes.
So if there is specifically
Yes.
mentioned that it should not be used.
Yes, it was specifically written. Now coming to typhoid, like we've seen the surgical complications of typhoid, the common ones are the intestinal perforation, cholecystitis with or without perforation of the gallbladder, and intestinal bleeding and osteomyelitis. The rarer ones are the pancreatitis, hepatic abscess, splenic abscess, pleural effusion, and orchitis. These are usually the come under the surgical complications of typhoid. So on evaluation of children for complications of typhoid, majority of these present, we look at the intestinal perforation first. So majority of these patients present with acute abdomen, and in patients that present with acute abdomen, it's important to differentiate if it is because of a typhoid perforation or it is because of gallbladder involvement. And this gallbladder involvement either because of cholecystitis or a GB prof. So the diagnosis of intestinal typhoid ileal perforation is often clinical, and it is based on features of peritonitis. But this peritonitis can also be seen in case of severe cholecystitis or GB perforation. So we move on to the investigations to identify specifically which one is the cause of the acute abdomen. And it is also important to perform investigations to ascertain the fitness for patient for surgery simultaneously. So at first, we perform the our routine complete blood picture, the electrolytes and KFT, because it is in here. One important feature is in a case of typhoid fever, leukopenia is classically described. But if there is leukocytosis, then it could indicate that the intestine is perforated. The other things like hypokalemia, metabolic acidosis, elevated urea and creatinine are common findings. Coming to imaging, pneumoperitoneum, it is important to remember, seen only in 55% of cases with ileal perforation, but it is more commonly seen in a case of typhoid colonic perforation, which is actually rare. But in that case, pneumoperitoneum is almost seen in 96% of cases. Ultrasound is used to look for gallbladder involvement, and if diagnosis is, or diagnosis is doubtful, the biopsy is helpful in those cases. Other tests like blood culture, urine culture, and peritoneal fluid culture are to be done with, but Vidal test here has limited role. Coming to the management, the general management of correction of fluid and electrolytes is of prime importance because children are usually unstable and require primary resuscitation before taking them for surgery. Target urine output of 1.5 to 2 ml per kg per hour is recommended, and blood transfusion also prior to surgery has been recommended before moving forward. Correction of associated coagulopathy and initiation of antibiotics is to be done before taking up the child for surgery. Antibiotics for typhoid fever here are recommended are third generation cephalosporins, fluoroquinolones like ciprofloxacin, aminoglycosides like amikacin. Metronidazole is also added to the regimen. Usually a combination drug regimen is to be given in a case of complicated typhoid fever. Ciprofloxacin, third generation cephalosporins, aminoglycosides and metronidazole. As we usually release yes. Pediatric means this is a particular article that I've taken from it is from an African paper, sir. This means surgical complications of typhoid exclusively have been dealt with from the Sir, they have written cephalosporins also were given. They gave 3 to 4 combination regimens, sir. Usme there were one regimen is ciprofloxacin, metronidazole, one is third generation cephalosporin with amikacin and metronidazole. That's a individual. Individual needed combination drugs.
Other thing the previous side also you said ultrasound is to be done only when there is a you in all patients. If you have a typhoid. Here if the patient comes in, it's to be 100%. Yes, sir. That's the references which we quote sometimes they can see it. Place where we work.
Coming to surgery, so surgery is to be done after appropriate and adequate resuscitation. Usually, a right transverse abdomen incision is sufficient to access the abdomen and move ahead. If the diagnosis is in doubt, particularly if it is a suspicion of perforated appendicitis, laparoscopy is usually beneficial. And in an adolescent, a midline vertical incision is given, and on entering the abdomen, the perforation is usually found on the anterocentric border of the bowel, and usually the terminal 60 to 80 centimeters of ileum is where we tend to find the bowel perforation. Rarely, it can also be seen in the jejunum and colon. It is important to examine all the organs from stomach to rectum, including the liver and spleen for other associated features. Coming to the procedure of choice, it is decided only after complete examination of the abdomen, because the site and the number of perforation may dictate the procedure of choice, and areas of impending perforation will usually appear paper thin on the serosal surface. Here we see a single perforation on the with an adjacent healthy intestine. Here we see a perforation with an adjacent double perforation here with the adjacent healthy intestine, but it could vary from this to even this picture, where we can see multiple perforations with almost a completely diseased intestine. So coming to what procedure to do, a segmental resection with healthy margins and ensures a segmental resection is done if we can ensure a healthy margin with no edema. Or if the perforation is too close to the ICJ, that is less than 3 centimeters from the ICJ, a limited right hemicolectomy is recommended. If there is a single perforation, or there are multiple perforations that are far apart, or there are so many perforations that the resection would result in a resection of almost the entire gut or a shortcut syndrome, then a simple pyogenic closure of that single perforation or those multiple perforations is recommended. Then, if the child is very sick or there is extensive bowel edema that is not safe to perform anastomosis, enterostomy can be done, either a double barrel or a divided ileostomy. Then coming to the closure of abdominal wall, importance is given here because if the wall is edematous, then a delayed primary closure is recommended uh, by the article that I've quoted here. Here they close the abdomen after 3 to 4 days because surgical site infection actually is a very common complication in typhoid fever. So post-operatively, about 60% of cases develop surgical site infection. As in, I've operated 4 cases. In adult.
What happened?
Sir, they were single perforation.
Yeah, we can.
Again, I'm trying to tell you that, yeah, the things which we code, which you when you start listening, like we have to give the right message. So
but
we cannot say that you just want to do that.
So as in, their sheath is closed, the skin and subcutaneous tissue are left open, or
Just to prevent surgical side
infection.
Our references is
Specifically written for typhoid cells because
That's fine.
typhoid
That's fine, they will hit.
because it is almost every literature that we
They stop doing it initially they used to do. Previous actually was of the opinion not to close skin for those stomach progress and not to close. Those things are personal, I don't know whether we can evidence-based medicine.
So, but we keep the argument there on the other side is that almost 60% incidence as a SSI count in the case of typhoid. That's
You can open it.
Even a category.
even complete divisions also documented.
You can open it.
Even substituting open करना है ना ऐसे एकदम बोले वो close नहीं करना sheet भी for that. What is the classification of SSI? Do you know the classification of SSI?
So skin subcutaneous infection or organ specific.
That's true. The standard question is a common question. This is CDC classification of SSI. Submit करना है. That you can decide. It's a grade 1 that you don't need to. it's just a message that the references which we quote again are not applicable to the place where we work. It can be Western, it can be like less privileged than us. Like if we are talking in an open forum that don't close their comment in typhoid, any of us won't agree with that. Because we have, that's why I asked, I must have done a lot of typhoid in my general surgery and during my pediatric surgery also between there. We never used to leave open. And infections are actually common in other operations also.
So they mentioned specifically the wall is 80, abdominal wall is 80 meters.
That's fine. Deep perforations and all, we do the from late abdominal wall is 80 meters. We used to open up appendicitis, dead presentations. We cannot give this message. That's what I'm trying to say.
Moving on to cholecystitis and gallbladder perforation. If the diagnosis is certain and there's no evidence of bowel gangrene, gallbladder gangrene on ultrasound, management is primarily by antibiotics and a cholecystectomy is recommended 6 to 12 weeks later. But if there's generalized peritonitis or evidence of GB perforation, then the laparotomy is done and the specimen of gallbladder with its contents is sent for culture. There is also a recommendation of tube cholecystostomy where to divert the instead of removing the gallbladder, tube cholecystomy is simply placed and a tube cholangiogram then later and removed. Cholecystectomy formally is done later in 6 to 12 weeks. That is also necessary. Coming to intestinal bleeding, here primarily this is seen as a complication of typhoid fever in the 3rd week, and here resuscitation with fluid and adequate appropriate amount of blood products, then antibiotics is usually sufficient. But these children are supposed to be admitted and observed for at least 1 week to 10 days because this intestinal bleeding spontaneously stops with these measures. And the child is supposed to be discharged only after ensuring that the bleeding has stopped. So conservative management itself is enough for intestinal bleeding. So when we look at post-operative complications as described, ileus is one common complication, but surgical site infection as described is seen in 50 to 60% cases. Abdominal wound dehiscence, that is full thickness dehiscence of the abdomen in 3 to 14%. Anastomotic leaks, intracutaneous fistulas, intraperitoneal abscesses, and a reperforation at a new site and all can also be is also documented. Other complications like hypoproteinemia, fluid effusions, etc. can also be seen. So to summarize, pediatric tuberculosis that of surgical concern are tuberculous lymphadenitis, abdominal TB, and rarely genitourinary TB. And when it comes to intestinal TB, the child can present with obstruction, perforation, or a persistent subacute obstruction that requires surgery. Then stricturoplasty versus resection anastomosis decided based on the type of and location of the stricture, and limited resections are also recommended. And these are the surgical interventions that are usually done in intestinal TB. Then coming to pediatric typhoid, complications commonly encountered are intestinal perforation, cholecystitis, gallbladder perforation, and bleeding. Then again, primary repair versus resection anastomosis based on the intraoperative finding. Surgical site infection again is very high, rate is very high in case of typhoid ileal perforation. Gallbladder perforation again, the management is either cholecystectomy or a tube cholecystectomy.
People or account for tuberculosis surgical management.